2012, Austria tried to fix a drug problem. They cracked down on one of the most misused pills on the market, flunitrazepam, better known as Rohypnol. The goal was to stop misuse, disrupt the black market, and make opioid treatment safer. Instead, employment fell, unemployment insurance claims rose, and health expenditures increased by almost 26% for opioid users. In the rest of this video, we'll give some background context, look at the policy itself, explore the consequences both intended and unintended, and look at how researchers measured these effects. Welcome to Econ Unpacked. The opioid epidemic is a major issue throughout the world. According to The Lancet, 60 million people worldwide struggle with the addictive effects of opioids, and 100,000 people die every year of opioid overdose. An often overlooked fact is that overdoses frequently involve combinations of opioids and other substances. In the first half of 2018, nearly 63% of opioid overdose deaths in the United States co-occurred with at least one non-opioid drug. Opioids are often mixed with another drug you've probably heard of, benzodiazepines, or benzos. The reason is that when these drugs are taken together, they amplify each other, making the high stronger, but also far more dangerous. This is because both drugs are depressants, meaning they slow one's breathing and dull the nervous system. Therefore, when they're taken together, the risk of respiratory depression, blackouts, and overdoses increase dramatically. It was because of this misuse that Austria decided to clamp down on one specific type of benzo, called flunitrazepam. Believe it or not, you've probably heard of this drug, just under a different name, Roofies. Roofies, trade name Rohypnol, is a particularly potent type of benzo. It acts fast, it's extremely sedating, and it lasts much longer than most others in its class. In small doses, it can cause deep sleep and amnesia. In high doses, blackouts and dangerous levels of respiratory depression. This combination made it notorious as a so-called date rape drug, but in Austria, it was also heavily used by people in opioid treatment programs. To patients, Rohypnol was a way to cope with withdrawal symptoms, anxiety, and the side effects of methadone. But to policymakers, that same reliance looked like dependence. Its potency, its reputation among the public, and its role in the black market made it seem like an obstacle to treatment. So, in 2012, Austria tightened restrictions with an aim of forcing patients towards safer alternatives. So what did this clampdown actually look like? Starting in December 2012, Austria put Rohypnol under incredibly strict control. Doctors now had to fill out special multi-copy prescription forms, with one copy kept by the doctor, one by the pharmacy, and one sent out to the health authority for review. On top of that, every prescription had to be signed off by a public health officer, who could alter or reject a prescription. Patients were capped at a 1-month supply, but they couldn't take it all home at once. Doses had to be picked up daily under supervision at a pharmacy, with strict monitoring that even included regular urine tests. And to make sure nothing slipped through the cracks, every prescription was logged in a nationwide database. In other words, overnight, a drug many patients depended on became almost impossible to get. So, what effect did these stringent measures have? Well, in one sense, the policy worked exactly as intended. Prescriptions for Rohypnol collapsed, falling from about 1 in 5 opioid users to just 1 in 20. The black market also seemed to dry up. Arrests for flunitrazepam nearly disappeared. However, beyond that narrow success, the picture is far less positive. Healthcare costs for opioid users jumped by more than a quarter, rising about 26.5%. Doctor visits and prescription drug costs climbed, and there was a 3.8% increase in antidepressant prescriptions, suggesting deteriorating mental health. Most strikingly, indicators of benzo withdrawal shot up by over 30%. I know I just showed a graph to illustrate this, but when we discuss withdrawals increasing, we should try to remember that this is not just a statistic. Withdrawal symptoms can be excruciating and debilitating. They can cause severe insomnia, panic attacks, trembling, waves of sweating and chills, relentless nausea and vomiting, and in the most severe cases, full convulsions. These acute symptoms can last weeks, while other effects can linger for months. These were people trying to rebuild their lives after the upheaval of addiction. Recovery depends on stability, on the small routines that make life predictable again. The sudden removal of Rohypnol tore that stability away overnight, and forced patients into one of the most punishing experiences of their lives, without warning or preparation. Some did try to switch to other benzos, but the substitutes were weaker and less effective. For many, it became hard enough just to get through the day, let alone hold down a job, which helps explain why employment among this group plummeted after the reform. Employment among opioid users dropped by 12.7%, and for those who remained employed, daily wages fell by between 6 and 7%. At the same time, unemployment insurance claims rose by 13.1%, with hundreds of additional claims attributable to the policy. For people already facing unstable health and employment, this was a major setback. Stability in work is often one of the clearest pathways to recovery. A steady job offers routine, income, and a sense of belonging that can anchor people trying to overcome addiction. Sure, a policy that drives them out of employment increases social welfare costs, but it also removes one of the few supports that help recovering addicts stay healthy and reintegrate into society. If these costs had come with clear gains in public safety, maybe this trade-off would look different. But the big public health payoff you might expect, fewer overdoses, never materialised. Opioid-related hospitalisations didn't fall. The crackdown eliminated Rohypnol, but the price was worsening health, destabilised lives, and reduced employment. If you found this video interesting so far, consider liking and subscribing. It would really help this new channel grow. Anyway, how do we know that this policy actually caused these effects? Well, the researchers combined two large sets of Austrian administrative data from 1998 to 2018. The first one was health insurance records. This covered every prescription, doctor visit, hospitalisation, sick leave, and health expenditure for about 1.5 million residents in Upper Austria. The second was social security records, which added information on employment, wages, unemployment benefits, and demographics. Together, these gave a full picture of both healthcare and labour market outcomes over 20 years. Next, they had to determine who was actually affected by the policy. Someone was labelled as an opioid user if they had ever entered substance use treatment or had a hospital record of an opioid-related event, like an overdose. This included people who entered treatment after 2012. The assumption is that they were likely already users prior to the policy. This kept the treatment group stable over time. For comparison, they drew a random 10% sample of non-opioid users. This group never received flunitrazepam, so it works as a control. The final sample was about 3,800 opioid users and nearly 1 million controls. These were tracked every 3 months for 30 months before and after the reform. Remember, the policy itself was introduced in late 2012 and made flunitrazepam prescriptions far harder to get, but crucially, the restrictions only applied to flunitrazepam, not to other benzos. That detail is important. Patients could still access weaker or longer acting benzos, but they weren't enough to prevent withdrawal. From a research perspective, this meant the study could isolate the effect of losing flunitrazepam specifically, rather than benzos as a whole. Finally, the authors used what's called a difference in differences design. They compared opioid users and the control group before and after 2012. If the two groups looked similar before the reform, but diverged afterwards, the difference could be attributed to the policy. This approach relies on what's called the parallel trends assumption. In simple terms, it means that without the reform, opioid users and non-opioid users would have continued along similar paths over time. And that's what the data shows before 2012. The two groups had different levels. Opioid users were younger, poorer, less educated, and had worse health, but their trends were moving in parallel. You can think of it in pretty basic maths. We take the change for opioid users, which is the outcome after the policy minus the outcome before, and subtract the change for non-users. Take employment as an example. Before the reform, employment for both groups was fairly steady. After the reform, employment for non-users stayed flat, but employment for opioid users dropped sharply. That extra drop-off is the difference in differences. It's the part of the change that we can reasonably attribute to the policy. You might assume that cutting off Rohypnol just pushed people towards other drugs like heroin or alcohol. However, there was no rise in heroin charges, no uptick in opioid-related hospitalizations, and no increase in alcohol poisonings after the introduction of the policy. This suggests that the harmful effects we discussed weren't caused by people switching to something more dangerous. They were caused by withdrawal and instability, when patients lost access to a drug they relied on. Austria's goal in 2012 was to make treatment safer by cutting off a drug seen as too prone to misuse. In the narrowest sense, the policy worked. Prescriptions for Rohypnol collapsed, the black market dried up, and misuse of flunitrazepam essentially disappeared. But those gains came at a steep cost. Patients faced severe withdrawals, healthcare spending jumped by more than a quarter, mental health declined, employment fell, and crucially, the reduction in overdoses never materialised. Policymakers thought that they could legislate away Rohypnol dependence. They cut off supply abruptly, with patients offered only weaker substitutes and no gradual tapering, leading to severe withdrawal. This didn't make treatment safer, it only made recovery harder. Austria got rid of Rohypnol misuse, but in the process it undermined the stability that patients relied on. and that instability was felt through health, work, and welfare outcomes. The lesson isn't about Rohypnol itself, but about the design of policy in general. Crackdowns can look decisive, but when we don't take into account the knock-on effects of our policies, the costs often appear through hospitals, unemployment offices, and in the lives of people trying to rebuild after misfortune. Austria tried to make treatment safer. Instead, it made recovery harder. If you'd like to see more videos about economics research and how economics unfolds in the real world, make sure to subscribe and hit the bell icon. This way, you'll be notified when we upload again. A link to the full paper can be found in the description below. And finally, I'd like to give a big thank you to the authors of the study for generously agreeing to proofread the script and help ensure its accuracy. Thank you for watching, and hopefully I'll see you next time on Econ Unpacked.